Let's discuss a bit now considerations for cost effectiveness evaluation. It's an incredibly important topic, especially with everything going on right now in the world's economy. We're in the middle of a pandemic. There are all sorts of potential implications there, not just to human life and culture, but to economics as well. So I think cost effectiveness has always been important, but will be even more so in the years to come. And I think it would be useful just to start from the 30,000-foot view, and I can't think of anyone better than Dr. Bress for that topic. What exactly does cost effectiveness mean as it pertains to cardiovascular disease? We hear a lot about it, but what does it actually mean? What are we trying to evaluate?
Yeah, thanks, Dr. Bott. Cost effectiveness essentially means an estimation of the incremental health gained by one treatment compared to another relative to the difference in the total cost of the two treatments after considering all costs of the downstream health outcomes of both treatments, usually over a lifetime. And the primary function of cost effectiveness analyses is to help healthcare decision makers, usually health systems, population health managers, and payers, optimize how to use and allocate their scarce or limited healthcare resources. And this involves a complex determination of the value or efficiency of interventions by assessing trade-offs simultaneously of costs, harms, and benefits of different treatment options. And cost effectiveness analyses are one way to help decision makers make these decisions. And to do so, cost effectiveness analysis combine these considerations into a single metric called the Incremental Cost Effectiveness Ratio, or the ICER. The ICER, like I said, is a ratio, and the numerator of the ICER represents the additional costs in dollars conferred when comparing two treatments, so comparing treatment A versus treatment B. And the denominator of the ICER is the difference in the health outcomes comparing treatment A versus treatment B, usually assessed in a single metric called the Quality Adjusted Life Year, or QALY. And QALYs are the most commonly used benefit measure in cost effectiveness analyses because it incorporates both the length of life and the quality of life, because QALYs adjust the length of life downward to reflect decreases in health-related quality of life as health conditions occur over time. And what the ICER means in terms of value or efficiency, the 2014 American Heart Association, the American College of Cardiology adapted the WHO's framework for value assessment of healthcare interventions and proposed interventions with ICERs of less than $50,000 per QALY, so $50,000 spent for each additional quality adjusted life year gained would be considered high value. So interventions that have an ICER below that number are considered to be high value. In contrast, interventions that have ICERs above 150,000 are considered low value, and interventions with ICERs in between those two are considered of intermediate value.
Well, that was really quite useful. I think we talk a lot about cost, but many of us, in particular the physicians I'm referring to, don't really understand what all that means. So that was a really useful summary.